Empezamos la primera sesión de las Jornadas Internacionales de Tuberculosis en su edición número 27. 27, dicho bien, ¿eh?
Exacto.
Yo soy Elisabeth Deig, soy médico internista, trabajo en el Hospital General de Granollers.
Yo me llamo Esteban Martinez, soy un médico de la unidad de VIH en el Hospital Clínic de Barcelona.
Y bueno, vamos a empezar la primera sesión. No sé si está a punto la presentación.
Es la mesa de GESIDA, es una mesa que hacemos conjuntamente con la Sociedad de VIH, de SIDA, de la Sociedad Española de Enfermedades Infecciosas y Microbiología Clínica, y a la que agradecemos siempre todo el apoyo que nos dan para poder realizar esta sesión. Y tenemos 4 ponentes de lujo.
Exactamente. Y empezamos con Nathalie De Castro. Nathalie es una experta en enfermedades infecciosas, trabaja en París desde hace más de 20 años y está involucrada en pacientes con VIH y gente inmunodeprimida. Es la coordinadora de muchos ensayos clínicos de VIH y tuberculosis, la coinfección, y coordina la ANRIM, coordinación con Brasil.
Sí, muchas gracias.
¿Sabe un poquito de español?
Sí, buenos días. Es un privilegio estar aquí y tener la oportunidad de compartir con ustedes algunas reflexiones sobre el tratamiento antirretroviral y la tuberculosis. Me gustaría mucho presentar en español, pero dado el riesgo que se termine en francés, es mejor que cambie para el inglés. Here is the summary of what I will be presenting over the next 20 minutes or maybe a little bit more. So as an introduction, I will start with epidemiology and challenges of HIV-TB co-treatment. I will go through some of the current guidelines, and then I will address the question of art in the context of TB by presenting the data we have from randomized clinical trials with efavirenz and integrase inhibitors. And I will also go through some of real-life data with cohorts. So just to start with, you know that HIV infection and TB are 2 major epidemics that remain an important cause of death in many countries in the world. And if we look at the latest WHO guidelines, report here, 10.6 million people fell ill with TB last year, and almost 12% died. Among the 1.5 million people diagnosed with HIV, almost 47%, that is 700,000 people were also diagnosed with TB, and almost 170,000 died. So this makes TB the major and the first cause of death among people with HIV. The burden of HIV-TB co-infection is partly related to the geographical coexistence of the 2 epidemics, and this is particularly the case in Africa, where 70% of the world's TB cases in people with HIV are diagnosed. So what about Europe? And if we look at the data we have from the European Union region, well, the most striking finding is the lack of data about the rate of HIV-TB co-infection. And you can see here that many countries are in dashed gray. So this is the case, for instance, in France, where we don't report the HIV status in the mandatory and the compulsory declaration that we make when we notify a TB case. So the consequence is that we probably underestimate the rate of HIV-TB co-infection in the region. So the average reported here is 3.8%. You can see that Spain here is in the 5 to 10% range, and rate of co-infection, and in France it's probably similar. The last estimation we have is around 7%. But however, you can see also that in some Eastern countries, the rate of HIV-TB co-infection is higher than 10%. So you know very well that there are many challenges for the treatment of HIV and TB co-infection. And so in this situation, art may be challenging. So I will review some of the challenges. So first, the co-administration of ART, TB treatment, and also prophylaxis or other opportunistic infections. Treatments share common side effects, like rash or hepatotoxicity, for instance, and there is a risk of treatment-related severe adverse events that is really higher in people co-treated for tuberculosis and HIV, and we know that this risk is 3 to 4 times higher than the risk of people who are treated only for TB. After ART introduction, immune reconstitution inflammatory syndrome may be difficult to manage. And finally, and most importantly, rifamycins in general, and rifampicin in particular, that is the cornerstone of TB treatment, is a potent inducer of hepatic metabolic pathways, especially CYP450 or gluconoridation via UGT1. And so this drug-drug interaction with rifampicin decreases exposure to many antiretroviral drugs and limits the number of drugs that can be used in this context. So I reported here this very nice table from the AIX guidelines that you know probably very well. Just going to this last part of the table. You can see that the decrease in drug exposure, and I hope you can see, maybe you cannot, so I will go through it. So the drug exposure to protease inhibitors, so here it's 70 to 80%. For NNRTIs, it's also 70 to 80%, except for efavirenz that is here, it's only 25%. And so with integrase inhibitors on the right here, the drug exposure of raltegravir or dolutegravir is 40 to 50%, and it is 75% with bictegravir, sorry. So you know that the risk of lower drug exposure is virologic failure and the potential emergence of resistance. So I won't go too much into more details in the PK data, but we will talk about this later, about some trials on raltegravir and dolutegravir. So since 2016, the treat all strategy was endorsed in low and middle income countries following the WHO recommendation. And so universal treatment is now recommended to reduce both mortality and HIV transmission, as you know. So if we focus on the WHO guidelines for low and middle income countries before 2018, efavirenz co-formulated with tenofovir and lamivudine in a single tablet regimen was standard of care. And in people with TB, there was no dose adjustment. Since the availability of dolutegravir, that is also co-formulated with tenofovir and lamivudine, it is recommended to double the dose when people are also treated for tuberculosis. So one of the reasons to replace efavirenz by dolutegravir is that dolutegravir has a higher genetic barrier and lower risk of emergence of resistance, of course. And this is really a great advantage when viral load monitoring is difficult, which is the case in many low and middle income countries. So in Europe, the treat-all strategy is also endorsed, and as this is the case for almost 10 years now, I think. And so what do the latest AIX guidelines say regarding ART in the context of TB? So efavirenz remains the preferred option in these guidelines, and integrase inhibitors are alternatives with the possibility to use raltegravir at the standard 400 milligrams twice daily dosage or the double dosage, and also dolutegravir at double dose. So in the next slides, I will briefly go over data we have from randomized clinical trials and to explain why we have these guidelines and why efavirenz remains the #1 option. So efavirenz was available since the early 2000s, and at the time, the other NNRTI that was available was nevirapine. So this is a busy table, but I just wanted to stop maybe on the first one. This is a non-inferiority trial. It was the CARINEMO trial. I'll focus on this one because it's the largest one. So it was a non-inferiority trial comparing efavirenz to nevirapine, and you can see here that the virological success rates were 64% on nevirapine and 69% on efavirenz, and the non-inferiority was not met. So this was the major trial that provides data on the comparison of the two drugs. We have other randomized trials. Another non-inferiority trial is here in the bottom line, but this trial had to be stopped for futility. You can see that the virological success rates were much higher on efavirenz, 85%, and only 65% on nevirapine. And we have a smaller trial that was also a phase 3 trial, but with only 140 participants. And here in this one, so with this limited number of participants, the virological success rates were similar after 1 year. So this was a trial from Thailand. So from those trials, efavirenz became the drug of choice, and the virologic success rates were roughly 70 to 75%. We had other phase 2 studies that I will not go through, but we knew from phase 2 studies that the PK interaction had really minimal impact on virological success. But you know very well that there were also limitations to efavirenz use. The drug could be poorly tolerated because of neurosensory adverse events. It could also cause rashes, as I already mentioned, or hepatotoxicity. And those adverse events were very difficult sometimes to distinguish from intolerance to TB drugs and led to TB treatment interruption or ART interruption. So that was a limitation. Another limitation is the low genetic barrier of efavirenz and the risk of resistance. So in this context, the integrase inhibitors were evaluated. So first, the first generation integrase inhibitor, raltegravir, and then a few years later, dolutegravir. And now I will summarize the data we have for these two drugs. I present you, so I tried, for the sake of time, not to go too much into details, but I will present the two studies that we conducted with Beatriz Greenstein from Brazil. These were the Reflate TB study and the Reflate TB 2 study. So what we knew from phase 1 and phase 2 studies and PK studies in general with raltegravir was that using doses from 200 milligrams to 600 milligrams twice daily provided the same antiviral efficacy. So this suggested that the variation in drug exposure might have no or little effect on virologic efficacy. So this was the rationale to evaluate raltegravir 400 milligrams twice daily, so the standard dose, and raltegravir 800 milligrams twice daily, along with efavirenz at the standard 600 milligrams dose. This is the phase 2 study. The main results are summarized here on the left-hand side of the slide. And so the study was conducted in Brazil, so most participants were from Brazil, but also in France. We showed that we found a similar proportion of virologic suppression at week 48. And here in the middle is the raltegravir 400 milligram arm with 76% of virologic suppression at week 48. I won't go once again into PK details, but the PK sub-study showed that the drug-drug interaction between rifampicin and raltegravir was lower than expected, and this was particularly the case in the standard dose raltegravir arm, in the 400 milligram raltegravir arm. Safety profile was good overall, but we had a concern about two severe hepatic events, and one patient unfortunately had to undergo liver transplantation, and both severe events were on the raltegravir 800 milligram arms. So it's probably toxicity was probably due to TB drugs, but we cannot rule out the role of high doses raltegravir. These results were the reason to validate the results in a phase 3 trial. So this was the Reflate TB2 trial. And in this phase 3 study, so we had a wider group, and participants were from Brazil, Côte d'Ivoire, France, Mozambique, and Vietnam. And so they were randomized to receive either the raltegravir 400 milligram standard dose or efavirenz at the standard dose of 600 milligrams. So you can see here that the rate of virologic success was 66% on efavirenz and 61% on raltegravir, with a 5.1% difference in favor of efavirenz. And you can see here in this small graph that the non-inferiority, that the lower bound of the 95% confidence interval crosses the non-inferiority margin, so we did not show the non-inferiority of raltegravir to efavirenz. And the difference between the two arms was mainly driven by virologic non-response. That was 22% on efavirenz and 29% on raltegravir. So here on the left, you have the details of the proportion of participants achieving virologic success at each trial visit. So you can see, if we focus on week 24, that there was a similar proportion of participants with virologic suppression. It was roughly 57%. And you can see also that in the raltegravir arm, the virologic success was achieved faster, but this is well known with integrase inhibitors. And you can see that after week 24, the raltegravir arm reaches a kind of plateau in the rates of virologic success, while in the efavirenz arm, virologic success continues to rise. On the right here, you have the other virologic outcomes with the 200 copies per ml threshold, and here the 1,000 copies per ml threshold. And you can see that roughly with both thresholds, in both arms, virologic success rates were 70%. So those were the main results of the REFLATE-TB2 trial. I won't go into details, but we conducted sub-studies to try to understand why we found different results between the phase 2 study and the phase 3 study. One striking finding was that the overall virologic success rates was lower than what was expected with efavirenz and raltegravir when we look at the results from the pivotal trials with these drugs. And so what we found was that female sex, adherence, and baseline HIV viral load were all predictors of virologic success, which is usual findings that we can find from other trials and with other drugs. A lower pill burden was related to the once daily ART regimen, so this favored probably the efavirenz arm, and adherence was not different according to country or sex. And so we wanted to better understand if the country may explain the difference between the two trials, because as I told you, the first trial, the phase 2 trial, was conducted mainly in Brazil, and the phase 3 trial was conducted in different countries from Africa, Asia, and also Brazil. So we found that there were some differences across country regarding sex and age, with younger participants from Africa, for instance, with CD4 counts. Participants from Vietnam were very immunosuppressed. The median CD4 count was below 50. And also baseline HIV viral load. And in Brazil, baseline HIV viral load was lower. Virologic success rates were higher in Brazil, and it was 75% on raltegravir versus, overall it was 75%, and compared to 58-67% maximum in the other countries. And the only independent predictor of virologic success was baseline HIV RNA. So this was probably the explanation of the difference between Brazil and the other countries. So I will move now to data on dolutegravir, and we have one non-comparative clinical trial that you must probably know. It's the inspiring study that was conducted by Kelly Dooley and her team. And this study evaluated dolutegravir, so double-dose dolutegravir, given twice daily and efavirenz at the standard 600 milligram doses. So we had 69 participants on the dolutegravir arm and 44 on the efavirenz arm. And as shown in the table, but also in the graph here, maybe easier to see, the proportion of people who achieved virologic success after week 48 was 82% on efavirenz and 75% on dolutegravir. And so you see that we had really few people with no virologic data or virologic non-response. And so it was following these results that the WHO recommended to also use dolutegravir in case of TB infection. So this is a more recent study. It's the SAFE-RIF study that has been published recently, earlier this year. It was a PK study evaluating the impact of high doses rifampicin at the dose of 35 milligrams per kilo compared to the standard 10 milligrams per kilo dosage. So once again, I won't go into PK details, but just you can see on these graphs even from far. So this is dolutegravir, this is efavirenz, and in red you have the high dose rifampicin, and in blue the lower dose rifampicin. And you can see that drug exposure is reduced in both arms with the higher dose rifampicin. On the right table, you see that the groups are very small. It's 30 participants per group. And so we have here the results of the virological endpoints. So this is, here you have the high dose rifampicin and the low dose rifampicin, and the virologic success rates in both groups is 85%, with differences here when you look at dolutegravir and efavirenz. So we have roughly 95% success rates on dolutegravir and 75% on efavirenz. But just this was a week 24 endpoint, and as I showed you, we know that at week 24 favors the integrase arm because virologic success is achieved faster, and it's not a predictor of the virologic success at week 48. So the results of I showed you on raltegravir raised some concerns about the impact of the twice daily dosing. And so as for raltegravir, the question is, can we do the same? Can we also use the standard dose dolutegravir in the context of HIV/TB co-infection? As for raltegravir, the PK data are reassuring and show that drug exposure may be sufficient to provide good and fairly good virologic suppression. So here, very briefly, I presented the results of two phase 2 trials that compared dolutegravir once daily to dolutegravir twice daily and at a double dose. So the first study here on the left is a Thai study that is ongoing. But they presented the first results of the first 40 participants that were enrolled. So once again, it's a PK study, and you can see the exposure to the drug in participants who had the once daily dosage is lower and is reduced. But in this limited number of patients, what they found was that virologic success rate was good. It was 90%. Once again, with a reduced sample size. This on the right here, you have this graph presenting the results at week 24 of the RADIANT trial that was published earlier this year. And so you can see here, that the virologic success rates with both dosages were above 80%. And what is interesting in this trial is that it's a placebo-controlled trial. So in both arms, people are taking ART twice daily. So we don't have the adherence issues that I mentioned earlier with, for instance, that we had in open-label trials. So finally, I move to data from real life, and I will just mention two cohorts. So the first one is the cohort from the Botswana national programs, and they were in Botswana, dolutegravir was available quite early, and so they started to use dolutegravir in people with TB from 2016. And so they presented the results of the first 700 or so patients that received dolutegravir. And what is interesting is that patients were on dolutegravir once daily or twice daily dosages. So what they found, and it is here on the right in this square, So they found that virologic success rates within so during the TB treatment was fairly high, but one important thing is that most participants or most people that were treated within the program were already virologically suppressed. It was like 70% of people. So this data cannot be extrapolated to people initiating ART, but again, reassuring data on once daily dolutegravir in a small cohort. And this is a more recent survey from the ID cohort. So they conducted this analysis among all the sites that participate to the ID consortium. And when they conducted the survey, most sites, like more than 95% of the sites, had transitioned to dolutegravir. And they looked at people that were taking dolutegravir, but also those that were taking efavirenz, either concomitantly, I mean during the same period of time, or also before the transition. So that's why we have 3 cohorts: those who were on efavirenz before the site's transition, and those who were on efavirenz after the site's transition, and those on dolutegravir. And if we look at the whole cohort here, they found that success rates were 59% on dolutegravir and 50% on efavirenz, but this includes people for whom we didn't have virologic data, and if they restrict the analysis to people with available virologic follow-up, they find that 80 to 90% of the participants were virologically suppressed and with a slightly higher virologic control on dolutegravir. So what's coming next? I just mentioned it here. I won't present the protocol, but this is the publication presenting the INSIGHT study. So this will be a randomized controlled trial. It's conducted in South Africa, and it will evaluate bictegravir at double dose. So people will receive Biktarvy, actually, so double dose twice daily. So to conclude and to give some perspectives, raltegravir and dolutegravir are alternatives to efavirenz for the treatment of HIV infection in the context of tuberculosis. But to date, efavirenz remains undefeated in phase 3 trials and phase 3 non-inferiority trials. Raltegravir is no longer the first choice for ART, but the results I presented you suggest that it is an acceptable alternative in selected patients with low baseline HIV RNA and with good adherence. And some of our findings from the REFLATE-TB2 trials may apply to the dolutegravir when administered twice daily. So we need really more data from real life and national programs, because I think that no large randomized clinical trial will be conducted on this topic. So we have data from the standard dolutegravir dose, as I showed you. These data are limited, they are reassuring, but I think we need to be cautious. But probably in people already suppressed on dolutegravir that develop TB, this may be an option. So I also need that I also think that we need to continue looking for new ART options in the context of the co-infection, but I'm not sure that non-inferiority trials and the usual FDA snapshot, that we use for virologic endpoints is the best way, because as I showed it, these trials are challenging and complicated to conduct. So we may need to consider other endpoints and need maybe to work on that. We have something ongoing. We have a study ongoing with bictegravir, but again, we have the same problems with drug-drug interactions, the twice daily dosage. So I don't know if it will really be an option that we will use on a daily basis. And if we look at the new regimens used for TB, rifampicin-based TB treatments have the same drug-drug interactions with antiretrovirals than rifampicin. And if we look at rifampicin-free regimens with the latest regimens that were evaluated, there is no significant drug-drug interactions between bedaquiline, moxifloxacin or linezolid, for instance, and ART. And so maybe in some selected patients and some difficult cases, we may consider to use these treatments, but this is a very personal thought. So I'll conclude with that, and I thank you for your attention and be happy to take a few questions if there are any.
Thanks, Nathalie. The questions will be coming at the end.
Our next, nuestro segundo conferenciante es el doctor Christian Kraef, que no sé si lo pronuncio bien. Christian es un médico internista y experto en enfermedades infecciosas que trabaja en el hospital de Copenhague, en el hospital Dick Hospitale de la Universidad de Copenhague, y su máximo interés en los estudios es en la epidemiología y los servicios médicos en cuanto a VIH y tuberculosis en Europa del Este y en países sudafricanos. Cuando quieras.
Thank you very much. Thank you very much for the invitation for me to speak on tuberculosis and HIV with a focus on Eastern Europe today. This is my agenda. First, I'll start to provide a bit of background why I think it is important to talk about TB and HIV in Eastern Europe, and then go on to talk about how we can improve outcomes in this population, whether there are any opportunities currently, and then, of course, we can't talk about this topic without also touching upon the war in Ukraine and potential implications for tuberculosis and HIV. So why talk about this topic here? These are some figures that most of you have probably seen before. This is on the left side. We have the global TB incidence on the top for people with and without HIV, which has been relatively stable, around 10 million a year over the last decade. On the other hand, for people living with HIV, tuberculosis incidence has been falling steadily over the last years. And also on the right side, you can see that's the same case for mortality in people living with HIV. So that has come down substantially. But if we then zoom in on Europe, we can see here on the left side, the total TB incidence has also been falling quite substantially over the last 20 years. But then on the bottom, you can see the light blue line, which is TB incidence in people living with HIV, excuse me, which has been going up initially and then has remained steady at an elevated level. And then on the right side, you can see where that is concentrated, where that co-epidemic is concentrated. The colors signify the HIV prevalence in TB incidence and relapse cases globally. And in our region here in Europe, you can see that it is particularly the former Soviet Union countries and Ukraine and Russia in specific that have HIV prevalence of between 20 to 50% in TB incidence and relapse cases. So that's one issue. And then the other one, as most of you also will be aware of, is multi-drug resistant TB. Globally, it is estimated to have come down a little bit. That's the green line, but diagnosis are still lagging behind. The blue line and have remained quite steady as well, around 200,000 cases a year, again concentrated in different countries, in a number of very specific countries in the world. And in our region, again, it is the former Soviet Union countries. It is Ukraine and Russia in particular. As colleagues, as Menzies et al. have nicely demonstrated this year in Nature Communications, the burden of disease measured in disability-adjusted life years for rifampicin resistant or MDR TB is almost 300,000 people per year in former Soviet Union countries. In the rest of the European region, it is only at about 3 a year, so a 100 times larger burden of disease in these countries as well. So these are the two main challenges we have in Eastern Europe. And why is that we have these challenges in Eastern Europe and the former Soviet Union in particular? You can see here that HIV, it's the fastest growing HIV epidemic in the world in Eastern Europe and Central Asia, with new HIV infections continuing to go up as well, also AIDS-related deaths over the last 20 years. And historically, this can be tracked back to this sort of perfect storm. It is not only TB and HIV in Eastern Europe and MDR TB, it is also hepatitis C and injecting drug use, which are partly overlapping. This is not a figure according to size, it's just to illustrate this. And the drivers of this syndemic is, of course, social disruption, loss of social status in the 90s coming and leading to poverty and also abuse of alcohol and injecting drug use. And then in an environment where, in particular, injecting drug use was criminalized, people were pushed into criminality and then did not have any form of access to treatment for their opiate abuse, and then were incarcerated, and then these prisons served sort of as an incubator for this syndemic, and also continue to do that, to do so up to today. So if we take a step back again, this is data from the RESPOND cohort, where it's a large cohort of people living with HIV across Europe, with more than 35,000 people and with HIV and almost 200,000 person years of follow-up. And we looked at the TB incidence in that cohort over the last 10 years. And you can see that this is relatively low overall, only 200 cases. But then if you stratify that by Eastern Europe versus non-Eastern Europe, so Eastern Europe is the beige countries here in our cohort, and versus the rest, you can see that incidence rate is 0.7 in non-Eastern European countries per 1,000 person years of follow-up. But in Eastern Europe, it's substantially and significantly higher at 5.7. A large difference. And if we then look at what is driving that, this is the population attributable fractions for modifiable risk factors that in non-Eastern European versus Eastern European countries, with the caveat that we, of course, could not adjust for all confounders such as socioeconomic status or injecting drug use. But still, smoking is something that's driving it in most regions. But in Eastern Europe, it is mostly, maybe not surprisingly, being off antiretroviral treatment can explain up to 40% of the TB incidence, whereas poor virological status, which is a composite of CD4 count and viral load, can explain up to 60% of the cases. And here, just to make sure that this is not additive, so they overlap, of course, so this is going above 100%. But this says basically that the main drivers for TB incidence is a lack of RT and poor virological status. And this is something that we all know about. This is the 1990 goals, basically, that we're talking about here. And if we take the data, most recent data from UNAIDS, we can see that in Eastern Europe and Central Asia, this is really behind the 95 goals. It's only 62% have know their status, 51% are on treatment, and only 48% of those are suppressed. And if you then look at the data in the Eurocedar cohort to look at how that translates to the immunological, virological status, here on the right side, the categories that we used, good is a CD4 count above 500 and a viral load under 200, and poor is CD4 count under 350 and viral load above 200, and then intermediate. You can see here in the stratification West, Central, East, and Eastern Europe, in the time periods 2000 to 2010, and then the most recent one here, 2016 to 2020, that IVS has improved in Western and Central Eastern Europe, and those two regions have basically become the same in terms of the coverage of the IVS. Whereas in Eastern Europe, you can see there's still 8.8% that have a poor status and 3.1% that don't know their status, and a much larger intermediate category. And that is clinics that are usually university hospitals, so quite probably a bias towards a better IVS than the population in general. And then there's the issue that is also playing into this of late diagnosis of HIV in Central and Eastern Europe. 55% are diagnosed late, and that is much higher than in Western Europe, where it's only about 40%. It has estimated a bit of an old data analysis, but in between 2010 and 2016, that about 15,000 excess deaths could be traced back to late diagnosis of HIV. But then there's also the issue of late diagnosis of tuberculosis. In the TB-HIV cohort, about 65% of people with HIV went with symptoms of tuberculosis, cough, fever, etc., for more than 1 month before they were diagnosed. And that also was reflected in mortality. So with a delay of more than 1 month, mortality was much higher here, the blue curve, than below 1 month. So what does that mean for outcomes, all of that? This is a study from Kraef et al. In Lancet HIV in 2016. They looked at 1-year mortality in people with HIV with a diagnosis of tuberculosis in Eastern Europe and compared that to Western Europe and Latin America. And the study found all-cause mortality in Eastern Europe of 29%. And almost all of that, 23%, was TB-related mortality. Here you can see how that compares. So that is Eastern Europe, the red curve here, all-cause mortality. Latin America, much lower, the green curve, and then the blue curve is Western Europe. And then you have tuberculosis-related mortality down here. The differences are even more substantial. And then after 2 years, the mortality was already at 35%. So 1/3 of those patients were dead after 1 year. And enrollment was between 2011 and 2013. So about 10 years ago. So we did a follow-up study in 2020 and looked at those that had survived the initial period. And all-cause, including the first 2 years, all-cause mortality in that cohort after up to 10 years of follow-up was 57.3%. And here we still have to account for a bit of loss to follow-up, so it's probably higher. So the mortality rate is 11.4 per 100 person years of follow-up, which is very high, taking into account that this population is very young at baseline. So when they were included, the median age was about 32. And you can see here, TB-related mortality in this cohort happened in the first 2 to 3 years. So it's a blue curve, and then remains relatively stable. But all-cause mortality continues to drop in this, again, very young cohort. So the question is, what do these young people die of? And we looked at causes of death and stratified that by the follow-up period. And early mortality, the first 6 months here, that's tuberculosis. And also the 6 to 24 months, tuberculosis is still very prevalent. But the longer we are from the baseline, the more other causes of death are becoming important. And that is not HIV/AIDS-related causes of death. That is other causes, which translate to things like acute intoxication, which means drug overdoses, suicide, accidents, or other violent deaths. So a very young population that is living under very harsh conditions, a lot of drug abuse and adverse environments that are killing these people. So how can we prove outcomes here? Well, this is probably the most important slide, and it links back to the slides about immunological, virological status. This is also data from the RESPOND cohort that's currently under review. And so people living in HIV in Europe that had diagnosis that were started, they were treatment naive, are treatment naive, and then were started on antiretroviral therapy. And then the colleagues looked at how the TB incidence after baseline, after RT initiation. And here you can see that it is stratified by the follow-up periods, 3 months, 3 to 6 months, 6 to 12, and then over 12 months. And really, TB incidence is highest in the first 3 months and 3 to 6 months at 14 at an incident ratio at 14.4, and then, incident rate 14.4, and then 5.9, and then dropping to 2.4. And then after 12 months, the incident rate is basically at the population background for people without HIV. If you start people on ART in Europe, and this is particularly Eastern European TB patients going into this, then after about half a year, and then after a year, you reach the risk of TB of the background population. And then it can also be said here that you can also really support this probably if you use isoniazid preventive treatment for latent TB as well in this early phase for those that are positive for latent TB. And then to make sure that this can be done, that RT and that people with tuberculosis are tested for HIV and treated with RT, and people with HIV are tested for tuberculosis and treated for tuberculosis. These healthcare services ideally should be integrated, but traditionally in Eastern Europe, this has not been the case. So this is data from a survey from 2018, where clinics in Eastern Europe, here the gray bar, and in Western Europe, the dark bar, were asked whether they had HIV and TB services in the same hospital, HIV and TB always treated by the same doctor, and TB treatment and follow-up at the same location. And here you can see that it's only about a third of clinics in Eastern Europe that had integrated HIV and TB services, whereas that was the case for almost all clinics in Western Europe. And then the other important, very important issue here, taking into account how many of these people have a history of injecting drug use, is the availability of an opioid or oral substitution therapy for all that needed. And that could only be provided by about 50% of clinics. And again, it has to be said here, this is probably biased towards an overrepresentation of good care, as these are mainly university hospitals, major university hospitals. This is also backed up by data here from European monitoring system for drug abuse. That is from data from 2021, looking at how many of those injecting drug users that should have opioid substitution therapy are receiving it. And the WHO target is 40%, but in Eastern Europe, mostly Eastern Europe, down here in Denmark, this is below, much below target. Russia is not on this list, Ukraine is not on this list, but in Russia, this is still illegal. Opioid substitution therapy is still illegal. So then, of course, if we want to treat tuberculosis properly, we need access to diagnostics and treatment. This is also from the survey in 2018, asking about access and availability of tests. A microscopy and culture was available broadly, but also rapid diagnostics test, meaning in particular gene expert, at almost all clinics in Eastern Europe. But there's at least there was a lack 5 years ago of access to culture-based drug susceptibility testing, with only half of clinics having that available and only half having interferon-based testing available. On a quite positive note, when the first TB-HIV study was done, the Lancet HIV paper that I showed, the RHZE was not necessarily the first-line treatment. There was a lot of different methods to treat tuberculosis in Eastern Europe, but that has improved since 2010, and this is, at least in these clinics, become standard. And then also access to new and repurposed anti-TB drugs is not that bad. Moxifloxacin is broadly available, linezolid as well, and beta-acylin 25%, and that has probably also gone up over the last 5 years since that survey was done. So there's some positive developments here. Do we have any opportunities, anything that is coming up and might help us? I would say one thing that is quite interesting is the urine LAMP test, the urine lipoarabinomannan point of care test. It's a lateral flow test recommended by WHO for people with a CD4 outpatient with a CD4 cell count below 100 and or signs and symptoms of tuberculosis. And this lipoarabinomannan is a part of Mycobacterium tuberculosis that's shed in urine when the immune system is not working properly. And then you can have a diagnosis, or at least an indication of TB, within a couple of minutes using this lateral flow urine test. So we looked at how broadly that was used and implemented in Europe. And as you can see here, the red countries, they don't have a policy, and they also do not implement the test. In Western Europe, in particular, maybe not surprisingly, because there are not that many patients, people with HIV that have AIDS and are eligible. But in Eastern Europe, it seems like the test is becoming policy, and in the green countries here, and also adapted and implemented in practice. And in Russia, the test is not part of a policy, but is available out of pocket. This, of course, does not say very much about how much the test is used in everyday practice in our clinics, but it seems like it is finding its way into TB programs in Eastern Europe. And then the other thing that we probably will and I think we will hear more about later today, is of course these revolutions in treatment of TB, 4-month treatments for fully susceptible TB, and then also the BPAL-M regimen for multi-drug resistant TB that really can make a difference in these populations in Eastern Europe. And but of course, there's an issue of access to drugs and price of drugs that needs to be addressed properly. So what about the war in Ukraine? What about the implications for tuberculosis and HIV? Here, that's an very interesting modeling study from last year that looked at where HIV prevalence was highest before the war in Ukraine here, mostly in the east, as well as tuberculosis. So mostly in the area where we see war now and armed conflict and displacement of populations. And currently, the most recent figures are that 6.2 million are externally displaced outside of Ukraine. They're mostly in Poland, in Germany, and Czech Republic, and Russia. And I think most expected that a lot of HIV and maybe also tuberculosis would come, and a little bit did, and that is mostly in absolute terms concentrated in neighboring countries. And surprisingly, data is relatively scarce on this issue. But what can be said is that, for example, Poland and Czech Republic received a lot less refugees with HIV than expected. Poland, at the end of last year, I think they expected about 8,000 people with HIV to register, and they only had 2,500. And in Czech Republic, only about 0.1% of all refugees had HIV, comparing to background prevalence in Ukraine of 1%, so 10 times lower than expected. Most of those, about 70%, are women and have a very high CD4 count of about 570, and very few are injecting drug users. In Czech Republic, only 2%. So much lower than what would have been expected in Ukraine, and that is very likely due to the fact that men are not allowed to leave the country due to the draft for the military, and also those that are injecting drugs and are the main or the weakest in terms of HIV and HIV-TB are socioeconomically not in a state to necessarily travel very far. So yes, there is an issue of HIV and TB in the refugees, but it's much smaller than expected, and there's work going on to link data for these refugees back to Ukraine to ensure that their treatment can be continued in a proper way, with also the information of their disease history being available. So what is probably more worrying is the situation within Ukraine. Here you can see that this is also the probability of forcible displacement, not surprisingly in the war regions, but that is again overlapping with HIV and tuberculosis prevalence, and those people, of course, went west. And what happened is that treatment, about 30%, up to 30% of people with HIV in Ukraine had treatment disruption, RT treatment disruption, and also interruption of their opioid substitution therapy, leading to increase in injecting drug use, and in line with the lack and destruction of healthcare systems, in particular in the East, an increase in HIV diagnosis. But then again, data is still very limited in that regard. But what can be said is that over the last 1.5 years, the HIV healthcare has stabilized in Ukraine, partly with mobile clinics. So that has been, with the support of, for example, the Global Fund, has been a huge success, so to say. But what is still worrying is, and even more worrying is what is going on in the occupied territories, because as mentioned earlier, in Russia, opioid substitution therapy is illegal. So most people, injecting drug users in the occupied regions, do not have access to opioid substitution therapy anymore, and also a lot of sexual violence is probably being perpetrated by soldiers, and then soldiers, particularly those that were recruited from prisons in Russia, have an HIV prevalence of up to 20%. So that is probably exacerbating the HIV epidemic in these territories, and there's no data at the moment. So the biggest issue is not outside of Ukraine. It's not necessarily inside Ukraine, but in the occupied territories of Ukraine. So now I come to my conclusions, and what is clear is that in Central Eastern Europe we've seen a lot of progress over the last decades, but the challenges remain in Eastern Europe and then also Central Asia, so mostly the former Soviet Union countries. And 70% of the disease burden for TB/HIV is located of the European or the European HIV burden is located in Russia. So what is important as if we want to address these problems is to ensure access to universal RT, unrestricted and legalized opioid substitution therapy, integration of HIV and TB services in one place, being person-centered, and access to drug susceptibility testing, culture-based drug susceptibility testing for TB, then the access to new and repurposed drugs and the availability, and then of course, the sufficiently sized health workforce and well-trained health workforce. So this is not only, I would say, academically interesting, but also, of course, a sort of a global health security challenge, because we're talking about multi-drug resistance here. Beta-kilin resistance is already appearing in Ukraine as well. But it's also about economic stability and prosperity, which is always important too if you want to prevent conflict and war. And then last but not least, it's a human rights issue. So I think it's important that we work together to improve outcomes here. Thank you very much.
Thank you, Christian. We will have the questions at the end. Y ahora es el turno para presentar al doctor Dinis Nguenha, que es un médico mozambiqueño que trabaja en Mesa y que nos presentará datos sobre el impacto en las respuestas del interferón gamma en antígenos específicos de tuberculosis en un contexto de alta prevalencia, utilizando los datos de dos estudios preventivos. Y bienvenido.
Gracias. So this presentation will start with a brief overview of the use of interferon gamma-releasing assays in the context of TB preventive therapy. And then I will proceed with the explanation of the HIVPTB trial. This was the main study that we used to draw this secondary analysis. And then I will proceed with the discussion of the results of the secondary analysis. So it is estimated that around a quarter of the global population is infected with Mycobacterium tuberculosis. And about 5 to 10% of those infected, they will eventually get symptoms and develop TB disease. So in order to decrease the proportion of those who get the disease, it's essential to diagnose and treat those individuals that are asymptomatic. So in the latest consolidated TB preventive treatment guidelines, the WHO recommends preventive treatment for all people living with HIV, regardless of the degree of immunosuppression and regardless whether we can test for TB infection status. Also, in the same guidelines, the WHO recommends a variety of TB preventive treatment regimens. So there are two main tests to diagnose TB infection. One is tuberculin skin test, and the other is interferon gamma-releasing assays. So both tests, they measure the immune response to TB-specific antigens. So obviously there's advantages and disadvantages of one test over the other, but in this presentation I'll only talk about the new generation IGRA, that is Quantiferon TB Gold Plus. This test was designed to have high sensitivity and specificity for tuberculosis infection. There's a difference for its other counterparts, IGRA, is that this new test has additional tube, that's the tube 2, that contains T-cell stimulation peptides for CD8. And apart from detecting TBI cases, this test was suggested to be used as a surrogate biomarker for preventive treatment response. So we did a research regarding using IGRAS for monitoring TB treatment response, and we find controversial results. Just to mention here that there is few studies that they've done and they are published, and then those few studies, there are many limitations regarding small sample size, study design, and the context that they were done. So this study, it was a randomized controlled trial in elderly people in China. This study was designed to evaluate the kinetics of interferon gamma levels along with TB preventive treatment. So in this study, they randomized 3 arms. The first arm, they give 8 weeks of weekly isoniazid plus rifampicin. The second group was given 6 weeks of twice weekly isoniazid plus rifampicin, and the third group was untreated controls. So quantiferon in this study was measured in 3 time points. The first time point was before preventive treatment. The second time point was after completion of TB treatment, and 3 months after completion of TB treatment. So they found out that the kinetics of interferon gamma levels were not statistically significant among the 3 groups. So in the end, they compare TB case, they match TB case and non-TB cases on baseline interferon gamma levels, and they found also no difference in interferon gamma levels with respect to time among those who received treatment and those who did not receive treatment. So to conclude that the kinetics of interferon gamma levels should not be used to monitor TB treatment efficacy. So that the study, this was a cohort study that aimed to evaluate the effect of a preventive treatment therapy on Quantiferon plus. Is one of the few studies that use Quantiferon plus. And TB preventive therapy significantly decreased interferon gamma levels. As you can see, these lines, it shows that the quantiferon was measured before treatment and after treatment, and they all decrease. And we can see significant p-values. So they suggest that we can use the kinetics of quantiferon as to monitor TB preventive treatment. So we had this unique opportunity of a large TB preventive drug trial in people living with HIV in TB endemic areas, which was the WIP TB study. And we draw a nested analysis to evaluate whether the annual kinetics of quantiferon plus responses change in this particular population. So I will bring a little bit of the context of the WIP TB study. That was the parent study that we used. So it was a parallel 2-part open label individually randomized programmatic trial. This study took place in 3 high burden TB countries in Africa, in Ethiopia, South Africa, and Mozambique. Participants were randomized to receive 3 months of high doses rifampicin plus isoniazid once. This is 3HP arm, and 3 months of high doses of isoniazid and rifampicin annually for 2 years. So this is the periodic 3HP. So they received twice, and this only once. And the third arm, they received 6 months of daily isoniazid. So TB was ruled out at month 0, month 12, month 24, using the WHO recommended for symptom screening. We also used chest X-ray. Sputum samples were collected to do gene expert and culture. And we dispensed treatment at month 0, month 1, and month 3 for all participants. For 6H arm at month 3, we dispensed 3 months of isoniazid supply. And for the periodic, they received also treatment at month 12, 13, and month 14. So we followed up these participants for 2 years for incident TB. We recruited participants from November 2016 to November 2017. Over 4,000 participants that were included. The median age was 41 years old. Around 40% of participants were women. All of our participants were people living with HIV, and they were taking antiretroviral therapy. So this analysis had two specific objectives. The first specific objective, we want to evaluate the kinetics of the Quantiferon plus during the first year in participants who take preventive therapy. And the second specific objective, we want to compare the kinetics among participants who took the second round of preventive treatment versus those who did not take treatment at all. So to answer those specific objectives, we divided our results in two types. We want to see categorical results. We treated our endpoint as a binary to see conversions and reversions, and also wanted to see quantitative measures. This is the median antigen levels in tube 1 and tube 2. So to interpret our Quantiferon results, we use manufacturing instruction, and our threshold cutoff value was 0.35 international units per milliliter. For the qualitative results of Quantiferon, we defined sustained negative if we didn't have no change from 2 consecutive negative results, sustained positive if we didn't have any change in 2 consecutive positive results, conversions or new infections when we go from a negative to a positive test, and clearance or reversions when we have a positive test that goes to a negative test. I'll bring a little bit of what was our Quantiferon positivity in this cohort and its coverage within countries. So if we see this yellow rectangular, I can call it, we can see the Quantiferon positivity at baseline, that it was pretty high. And then if we stratify by country, South Africa had the highest Quantiferon positivity at baseline compared to Mozambique and Ethiopia. And at baseline, we had a high coverage. 94% of participants were tested using Quantiferon plus. But again, this coverage, it decreased along the subsequent time points, and it reached its lowest levels in month 3, in month 24, the 3 time specific time point, where South Africa only reached to test 6% of their participants and Ethiopia 11% of their participants. So in our analysis for the second specific objective, we only restrict this analysis for Mozambique just to avoid potential sampling bias, because there's a huge difference of coverage in this time point. So for our results, we want to see the kinetics in the first year. So we see paired results of month 0 and month 12 between Quantiferon results. So overall, around 80% of participants, they converted their Quantiferon results from month 0 to month 12. Of course, the coverage proportion of conversions were not different by study arm, and there was a variability within countries, and the highest figures, they were showed in Ethiopia. Ethiopia has the highest coverage rate, conversion rate. So around 7% of participants reverted their results during the first year, month 0, month 12. Again, there is no difference by study arm in the proportion of reversion. And again, there is a variation within countries, with Mozambique showing the lowest figures and Ethiopia the highest conversion rate during the first year. So for the quantitative results, we want to see the median levels. when we compare the median levels of antigen 1 minus nil, antigen 2 minus nil, that's the tube 1 and tube 2, among participants who had a positive quantiferon at baseline, we did not find any statistical difference in the final levels between these two tubes by study arm. As you can see, our p-values are not statistically significant. But when we compare these median antigen levels at baseline from tube 1 and tube 2, we want to see what happens when we compare a baseline median levels. We see among those who reverted their results and those who remained infected, we see a statistically significant lower median levels from participants who reverted their results compared to those who remained infected. Here I'll show the kinetics of the second year period. Again, we are comparing month 12. Okay, sorry, I was speaking very far from the microphone. I hope that you understand everything. Sorry. Okay, so to see these results for the month 12, I just want to remind that here we are comparing two arms, participants who received preventive treatment and those who didn't receive preventive treatment at all. Just to remind that because we had lower coverage during the month 24 in Ethiopia and South Africa, this analysis was restricted to Mozambique only. So when we saw our categorical results, with the participants who reverted their results, they didn't show any statistical significant result. But when we compared participants who converted their results, we see that the proportion of conversion was lower among individuals who received the second round of preventive treatment compared to participants with no treatment. So it seems like receiving the second round of preventive treatment, it has a negative protective effect. It protects against new infection. So we looked again at quantitative results with the median levels of antigens. And again, here we didn't find any statistical difference in the median final levels among participants who reverted their results and those who remained infected, regardless by study arm. No statistical significance in these differences. And also we saw the same around participants who converted their results and those who were sustained negative. There is no statistical difference by study arm among converters and sustained negative results. So to conclude our analysis, despite the administration of preventive therapy, the annual TB infection rate in a cohort of people living with HIV was really high. If we remember the first table of conversions, we had like around 80% of participants, they converted their results. We didn't find any difference in Quantiferon plus response, regardless of the preventive therapy regimen that they were using in this trial. And this study raises the hypothesis of a potential prevention of infection effect of preventive therapy. So I want to thank all the participants from the original HIVPTB study that took place, and many of the investigators that they were involved in the design and accomplishment of this study. And this is our team in Mesa in Mozambique. Thank you.
Thank you, Dinis. Ahora pasamos a la última presentación y es un placer para mí presentar a la doctora María Velasco, amiga, compañera en el Hospital Clinic durante varios años y una especialista reconocida en el campo, varios campos, medicina tropical, también tuberculosis. Ella es la coordinadora de investigación en el Hospital de la Fundación Alcorcón en Madrid y también profesora de la Universidad Rey Juan Carlos. Y hoy nos va a hablar sobre un patógeno que teníamos muy presente en el pasado, que no ha desaparecido, que vale la pena tener presente, una micobacteria típica, Mycobacterium avium, y actualizará la epidemiología, la clínica, el diagnóstico y también el tratamiento. Gracias, María.
Muchas gracias, Esteban, por esta presentación tan amable. Para mí es un placer estar aquí y repetir. Me encanta esta jornada. Bueno, vamos a ver un poquito la Mycobacterium avium en personas VIH. Esta es la agenda, un poco de la infección en general, epidemiología y manifestaciones clínicas. Un recordatorio de que el complejo avium son 3 especies, pero que mayoritariamente aparece avium y es de la que más vamos a hablar hoy, que son unas micobacterias ubicuas que están en el ambiente, tierra, agua, que producen sobre todo producen afectación pulmonar, pero en pacientes inmunosuprimidos el recordatorio de que pueden producir enfermedad diseminada con bacteriemia y también linfadenitis, igual que en los niños. ¿Y cuáles son los factores de riesgo para adquirir esta enfermedad en la población general? Bueno, pues se sabe bien que no tiene correlación con el sexo, la raza o la forma de transmitir. Y sí que hay estudios que nos muestran que puede tener correlación con factores ambientales. Los nórdicos encontraron correlación con el uso de piscinas o consumo de pescado crudo. También con las manipulaciones respiratorias, como el uso de la realización de broncoscopias, inmunosupresión reflejada por diversas formas, bajos CD4 en personas VIH o tratamiento con estimulante de colonias. Y luego también tiene un factor genético que se ha visto que las personas que tienen los alelos de clase HLA que se muestran tienen más probabilidad de infectarse y desarrollar enfermedad por el Mycobacterium avium. Y luego un aspecto muy importante que es la localización geográfica. Esta bacteria tiene una predilección geográfica que ya se describió en el pasado. Los países más ricos tienen mucha más probabilidad de tener de tener personas infectadas por esta bacteria, y esta peculiaridad geográfica se presenta incluso dentro de los propios países, en Estados Unidos y Canadá, entre el sur y el norte. Y clásicamente la era también cuando teníamos muchos pacientes VIH inmunosuprimidos, pues claramente en Europa teníamos menos infección que en Estados Unidos. Y un trabajo en red de un estudio en 20.000 pacientes de varios países con muestras pulmonares, pues objetivó la gran variabilidad, en este caso del complejo Mycobacterium avium, presentarse en los países que están en tonos naranjas y rojos tienen más probabilidad, y tenemos Estados Unidos, Australia, el norte de Europa, también está aquí Argentina. Y dentro de Europa es muy variable la presentación, e incluso no solamente del Mycobacterium avium, sino que la forma de distribuirse las micobacterias atípicas dentro las no tuberculosas dentro de cada país también es muy variable. O sea que es una bacteria que tiene un componente importante geográfico. Y en este sentido, algunos en Europa, en Estados Unidos, en Australia y en algunos países de Europa han objetivado que en las últimas décadas está incrementándose la enfermedad no tuberculosa, tanto enfermedad, como se puede ver aquí, la prevalencia en Estados Unidos, como prevalencia en personas mayores de 65 años, como también en el número de cultivos positivos de esputo. Y un trabajo hecho en Australia que hace una predicción de cuántas serán las muestras o la enfermedad por micobacterias no tuberculosas, pues se ve que claramente, tomando los datos que hay entre 2015 y 2020, pues hace una predicción de un ascenso de la presencia de esta micobacteria en la población general. Y aunque es claro que en las personas que no tienen infección por VIH ha aumentado la incidencia, también sabemos que en las personas VIH claramente ha disminuido y vemos mucho menos esta enfermedad. Es bien conocido que es una infección que aparece cuando tenemos una inmunosupresión severa, cuando las personas tienen menos de 50 CD4 y otros factores de riesgo, ya hablando de las personas con VIH, pues además de la inmunosupresión, en la era del tratamiento antirretroviral, pues se sabe que el tener carga viral detectable o aquellos que están en tratamiento antirretroviral pero no logran controlar la carga viral, bien porque no se toman el tratamiento, por resistencias o por otros factores, así como las personas que han tenido enfermedad oportunista, tienen mayor riesgo de infección por Mycobacterium avium. Y, como se puede ver, todos estos factores lo que nos están marcando son un grupo de población más inmunosuprimida, peor controlada, o sea, un grupo de población más desfavorecida. Y si en la era pre-HAR teníamos una incidencia de infección diseminada con bacteriemia por Mycobacterium avium que oscilaba entre el 10 y el 47, el advenimiento del TAR y el control de la carga viral y la mejora de los linfocitos CD4 ha llevado a un descenso de 10 veces la incidencia de esta enfermedad diseminada. Esto es un trabajo que se hizo en la Universidad de Duke durante más de 15 años. Y, de hecho, en los datos que recopila el Ministerio, entre las 10-12 enfermedades más frecuentes diagnósticas de SIDA, pues el Mycobacterium avium ya no aparece. Y en la encuesta, en el corte transversal que se hace todos los años para evaluar cuál es la situación de los pacientes que acuden al hospital o están hospitalizados con infección por VIH, pues en los últimos 15 años, más de 15 años, pues vemos que esta infección, teniendo un número, esto es 300, perdón, un número de hospitalizados entre 300 y más de 1.000, pues la presencia de esta infección en los pacientes es menor del 1%. O sea que ahora mismo en nuestro entorno no es una enfermedad que veamos con mucha frecuencia, quizá porque nuestros pacientes están bien controlados. Sin embargo, si colocamos la evolución de los CD4, que como hemos comentado es el factor clave para desarrollar esta enfermedad, pues vemos que menos de 200, aunque ha ido bajando, pero tenemos entre un 10 y un 30% de personas. Es decir, que tenemos un número de personas inmunosuprimidas de forma importante y, sin embargo, vemos poca enfermedad por Mycobacterium avium. Ha cambiado el perfil de estas personas que vemos antes y después del tratamiento antirretroviral. Pues tenemos trabajos, no son de nuestro entorno porque tenemos pocos pacientes, hay muchos trabajos de Estados Unidos y de Asia que nos pueden responder a estas preguntas, aunque muchos son con pocos pacientes y son algo heterogéneos. En este trabajo, que es el que he mostrado antes de la Universidad de Duke, se recogieron durante este periodo 330 pacientes y se analizan las características clínicas y demográficas antes y después del tratamiento. Y lo que se puede concluir, aunque la presentación clínica es muy similar, la presentación clínica de la enfermedad diseminada es muy parecida, pero hay algunos grupos que están más representados en Estados Unidos, como son las mujeres y las personas de raza negra no hispanas. Otro trabajo, realizado en Corea y realizado no en personas con enfermedad diseminada, sino en personas que tienen cultivos positivos también en esputo. 34 pacientes, fijarse en 21 años, qué poca cantidad de pacientes, pero sí nos muestran que la distribución de la enfermedad es pulmonar 60% y extrapulmonar 41%, y la mayoría de los extrapulmonares no son diseminados, es afectación de los ganglios linfáticos. Aquí hay 34, pero eran más pacientes, excluyeron 17 porque no tenían ningún síntoma. ¿Qué más nos muestra este estudio respecto a las características clínicas? Pues que la enfermedad por micobacterias atípicas se diagnostica alrededor de 6 meses desde el diagnóstico del VIH. Hay otros trabajos que ponen el margen entre 3 y 6 meses y que muchos de ellos tenían enfermedad avanzada. La mayoría tenían otra enfermedad oportunista ya diagnosticada. Y que el grupo, comparando el grupo de pulmonar y extrapulmonar, el grupo que tenía enfermedad extrapulmonar eran más jóvenes al diagnóstico del VIH, tenían un mayor índice de masa corporal, y los CD4 al diagnóstico del VIH eran un 50% menores, no alcanzó la diferencia significativa, probablemente por el escaso número de pacientes, pero tenían una inmunosupresión peor los del grupo extrapulmonar. Y algo muy interesante que describe este artículo es que encontraron casos de Mycobacteria avium y Mycobacterias no tuberculosas en pacientes que tenían carga viral suprimida, tanto en el grupo de tuberculosis pulmonar como en el grupo de tuberculosis extrapulmonar. El grupo de tuberculosis pulmonar se asemejaría a la presentación que tienen los pacientes que no están inmunocomprometidos. También en la era del tratamiento antirretroviral hay varios casos anecdóticos que los traigo porque son muy curiosos, de presentaciones muy atípicas, como esta de un pseudotumor periportal, y otras que en el seno de una reconstitución inmune un paciente hizo infartos esplénicos masivos, o una pericarditis también en el seno de la reconstitución inmune. Y todas estas presentaciones y todas las manifestaciones clínicas se han analizado el patrón de hospitalización que tiene en el trabajo de la Universidad de Duke, que es uno de los más numerosos, 330 pacientes, y compara el patrón de hospitalización entre pacientes que se diagnostica el VIH recientemente, que serían los que van a recibir un tratamiento antirretroviral más eficaz, y aquellos que ya se conocía durante un tiempo prolongado la infección por VIH, que estarían en los que están en el periodo inicial y no han recibido tratamiento antirretroviral eficaz durante mucho tiempo. Y miran cuántas hospitalizaciones hay un año antes y 2 años después de tener el diagnóstico de Mycobacterium avium. Y como se puede ver, el número de hospitalizaciones, esto es un año antes hasta 2 años después, en ambos grupos es bastante numeroso. Es el bloque negro indica hospitalización. El hospitalizarse antes posiblemente está marcando los pacientes que ya tenían otras enfermedades oportunistas, pero la hospitalización después, que es significativamente superior en el grupo de VIH ya conocidos, que son los que tenían menos acceso al tratamiento antirretroviral, es superior al de nuevos diagnosticados. Se mantiene el porcentaje de hospital, o al menos hay un porcentaje importante de hospitalización hasta 2 años después. Es decir, que la presencia o el diagnóstico de esta enfermedad nos está marcando una población que va a necesitar cuidados, o bien por complicaciones de esta enfermedad, o bien porque se asocia a otras complicaciones o a otros problemas que trae la inmunosupresión. Y viendo esta gráfica de la importante tasa de hospitalización relacionada con la infección por la micobacteria, es fácil deducir que va a tener una tasa de mortalidad bastante elevada. Desde el periodo, desde la era antes del tratamiento antirretroviral, se conoce que el diagnóstico de una micobacteria diseminada multiplica por 3 la probabilidad de morirse, y en este trabajo que se realiza la tasa de mortalidad estandarizada y se compara entre los pacientes que no han recibido tratamiento antirretroviral y los que sí. Por supuesto, los que nunca recibieron tratamiento antirretroviral tienen un exceso de mortalidad muy grande, pero los que han recibido tratamiento antirretroviral tienen en los 5 años después de diagnosticarse una enfermedad diseminada por Mycobacterium avium, tienen una probabilidad, una tasa de mortalidad ajustada nada desdeñable. Y si vemos la supervivencia de los pacientes con Mycobacterium avium diseminado, comparando los que tenían diagnóstico reciente con los que ya lo tenían establecido, es decir, los más antiguos, vemos que la mortalidad al año es bastante parecida, corre paralela, pero a partir de un año los que tenían el diagnóstico previo de VIH estarían con peor situación inmunovirológica, son los que continúan teniendo, los que tienen una diferencia de mortalidad importante. Otro trabajo en China, en Shanghái, que evalúa también la probabilidad de morirse de pacientes con enfermedad diseminada por micobacterias no tuberculosas. Son 379 casos durante 8 años, todos en la era del tratamiento antirretroviral, y compara los pacientes que tienen una enfermedad localizada a los que tienen una enfermedad diseminada, y se ve claramente como la probabilidad de morirse es mucho mayor en los que tienen enfermedad diseminada, y ellos hacen un cálculo de la probabilidad de morirse desde 1 año a 7 años, y va de 15% a casi 28%, una tasa acumulada. ¿Y cuáles son los factores de riesgo? Han cambiado desde la era pre-HART, desde la era antes del tratamiento antirretroviral eficaz a la era actual. Pues en la era antes de disponer de tratamientos eficaces, factores de riesgo de mortalidad era la cantidad de bacteria y la que se medía por el recuento de colonias, y el retraso tanto en el tratamiento de la micobacteria como en el retraso del tratamiento antirretroviral. Después en la era del tratamiento antirretroviral tenemos algunos datos discordantes, sobre todo porque algunos vienen de cohortes que son pequeñas y que posiblemente introducen algún sesgo, pero algunos son muy coincidentes, que se mantiene la bacteriemia medida por el tiempo a la positividad. También aparece la cantidad de virus, a mayor bacteria, a mayor virus, mayor riesgo de morirse, y también el tener un recuento de CD4 más bajo. En un estudio más grande se vio también que tener la edad avanzada, la enfermedad diseminada y haber empezado el tratamiento antirretroviral antes del tratamiento para las micobacterias, así como, curiosamente, el uso del linezolid se asociaba a un riesgo de mortalidad. Y para casi concluir, una pincelada de la reconstitución inmune. La Mycobacterium avium produce también un cuadro de reconstitución inmune parecido al que produce Mycobacterium tuberculosis, y en este trabajo que se hace en Australia durante 10 años se encuentran 26 pacientes y se analiza la prevalencia de síndrome de reconstitución inmune, así como se compara las características de los que lo tienen y los que no. Y los pacientes que tuvieron reconstitución inmune, que casi llega a un 40%, habían tenido enfermedades oportunistas 3 meses antes, habían tenido un mayor descenso de carga viral, y en este trabajo no se encontró una diferencia en la cifra de CD4 entre los grupos que tenían reconstitución inmune y los que no, aunque sí que hay algún otro trabajo que esto sí que lo señala como un factor de riesgo. Lo que sí que encontró este grupo es que los síntomas de reconstitución inmune son los mismos, son fiebre, astenia, aumento de adenopatías, no encontraron diferencias en la presentación. Lo que sí que encontraron es que el grupo que tenía reconstitución inmune tenía una duración de los síntomas mucho más prolongada, hasta 6 meses. Y algo también importante es que no hubo diferencias de mortalidad ni a los 30 ni a los 60 días entre el grupo que hacía reconstitución inmune y el que no. Y esto sí que es consistente con otros trabajos, aunque tengan pocos pacientes, han analizado la reconstitución inmune. Sobre tratamiento, pocas novedades. Esto se mantiene igual desde hace varios años. Las guías de HIVPositive, igual que las guías de la Sociedad Europea recientemente actualizadas, siguen diciendo lo mismo. No es necesario realizar profilaxis si el paciente está con carga viral indetectable. Se puede hacer hasta que tenga carga viral indetectable, y el tratamiento se puede hacer con claritromicina de tambutol más menos rifabutina según los pacientes. Y nada más, estas son las conclusiones. La incidencia del Mycobacterium avium ha disminuido de forma muy, muy importante. Ahora en nuestro entorno puede ser casi una enfermedad que puede ser anecdótica. Sin embargo, debemos seguir estando alertas y activos para diagnosticar y tratar la enfermedad, porque la enfermedad por Mycobacterium avium diseminado sigue siendo un diagnóstico con una mortalidad muy elevada, no solamente en el momento del diagnóstico, sino también unos años después. O sea que es un diagnóstico que nos debe alertar. Afecta a poblaciones minoritarias en los países en los que tienen más volumen para valorar esto. Y estas poblaciones minoritarias posiblemente también lo que está reflejando es que hay la enfermedad afecta a personas que no tienen buen acceso al tratamiento, no tienen buena adherencia y no están bien vinculadas a los cuidados sanitarios. Por tanto, es una enfermedad centinela que tenemos que seguir teniendo en cuenta. Y esto es todo. Muchas gracias.
Muy bien, María, no te sientes, y también pido que Dinis, Cristian, Nathalie, también subáis.
Ahora empezamos el debate. Tenemos unos 20 minutos para el debate y os animo a formular preguntas, tanto los que estáis asistentes aquí como los que estáis conectados online.
Levantáis la mano para que el micrófono se pueda dar, os identificáis y podéis hacer la pregunta. Y mientras tanto recordamos a nuestros compañeros, asistentes conectados online, para que también puedan emitir sus preguntas a través de la web. Por favor.
Esteban, buenos días a todos, buenos días en español, y no
por
sé
favor.
si a la doctora Castro. Primero, muchísimas gracias. Vengo de Colombia, Fernando García. ¿Qué piensa de los resultados del TB Radiant con dolutegravir una vez al día? Y si pensaría de que esa sería la opción para los países de recursos limitados, donde no aumentaría los costos con la administración de doble dosis.
Have you got the question? If you want to reply in English, you can do that, and it will be translated.
Yeah, I prefer to answer in English. Sorry. No, that's a very good question. So I have kind of mixed feelings about the results, because we have really the data on dolutegravir are from phase 2 trials, and as I showed you, we had very good results from the phase 2 trials on raltegravir. But when we moved to phase 3 trials, for some reasons that we haven't captured in the phase 2 trial, we failed to show the non-inferiority. Obviously, dolutegravir and raltegravir are two different drugs. So I think given the high genetic barrier of dolutegravir, this may be safer. You know, maybe we have less concerns about virologic failure with dolutegravir. But again, the resistance to dolutegravir is rare, but it has been described precisely in the settings of co-administration with rifampicin. So there's a little bit of concern. So I think in people that are already on dolutegravir, taking their treatment controlled, this may not be such a big issue. But I think the problem is that you need to monitor viral load very frequently. Because if you have people who's replicating with viral load, you know, for 3, 4, 5 months, you don't know what will happen in terms of resistance. And maybe a few years later, we will see dolutegravir resistance emerge, particularly in countries where the rate of HIV-TB co-infection is high. So if you have frequent viral load monitoring while on TB treatment, and you can capture very early people that are failing, why not? I would say why not, but we don't have the data. Again, I'm a little bit, you know, mixed feelings. When starting treatment, I'm not sure I would start with once daily treatment, but maybe in people already treated, why not? But once again, we don't have the data. And also there is one thing, you know, when we used in the trial, when raltegravir failed, we had integrase mutations, obviously, but we could use dolutegravir after. This did not impact dolutegravir efficacy, but with dolutegravir it will be different. If resistance emerge, you will not use dolutegravir afterwards. So that's why I'm a little bit, you know. So maybe in patients already controlled, why not? In patients starting ART, I wouldn't start with single dose. And with double dose, really monitor adherence is a very important issue. When you cannot, again, have viral load monitoring, frequent viral load monitoring, which for me is the best measure of adherence, of course.
Gracias.
Gracias. You mentioned that you found resistance in reflate studies.
Yeah.
Was it a kind of resistance that could not you could use dolutegravir afterwards?
Yes.
So that's an early resistance.
Yeah. Yeah.
That's good to know.
Yes, yes, Chris Vilaplana from German Stries i Pujol. My question is for Dr. Nguenha. It is about the feasibility, because you showed that preventive treatment prevents reinfections. So how feasible is to implement this on the field? And the second question is if you are going to continue these studies. Thank you.
Okay, thank you. If I get correctly, the first question, you're asking about the feasibility of implementing the Quantiferon plus testing in settings like Mozambique, South Africa, and Ethiopia, where we did our study. So,
not the Quantiferon, the preventive treatment.
Yes. The preventive treatment, yes, it is feasible, and then as is recommended by the WHO in all the latest guidelines, we should give a preventive treatment for all people living with HIV. And then we know that HIV is the most is one of the diseases that kill the most people in Africa. So implementing preventive therapy is the first and the best option that we have to prevent progression from latent TB to active TB disease. So I would urge to all national TB programs to continue working hard on supplying this preventive treatment and making sure that all patients that are that we can include, they make sure that they're in treatment and the success rate is very high.
Hi, I'm Samiksha Gimire from Netherlands University Medical Center, and my question is to Dinis. I'm curious about the role of IZRA in identifying patients with or persons with latent TB infection, because what happens in Nepal is that on a population level we are BCG vaccinated, which means that when you perform a tuberculosis skin test, you get a false positive. So can we rely on IGRA for ruling out latent TB infection?
I could say yes, because if we see the IGRAs, they have this, I can say, the advantage of not having a cross reactivity with the BCG vaccination. So the specificity and sensitivity is really high using the IGRAs. So moving from tuberculin skin test to IGRA, this is the best option. So it's really recommend to use IGRAs.
We can say that then at that point, patient or a person is not yet latently infected, correct?
That is debatable.
Okay.
Yeah, it's not like 100% saying that, okay, the IGRA tell us that yes. Like many studies have been done, and then because there is this controversial in IGRA identifying persons who revert or who convert. Because in the first point, you don't know if you receive the patient from the first time, if maybe he had a positive test that reverted, and then you test for IGRA, it can be converted or not. So it's debatable, I can say that.
Thank you for the clarity.
Nathalie, do you
Maybe I can just comment on that. I must say I'm not an IGRA fan, okay? So I start with that because, okay, for me, IGRA measures two things. It tells that you have been exposed to TB, maybe, and it says that you are immunocompetent, because if you're not immunocompetent, IGRA will be negative. So just to answer to that, if you have people with very low CD4 counts, you cannot rely on IGRA to say that people have not been exposed. So I guess if you have a patient in Nepal with less than 200 CD4 counts, you must consider that he has been exposed, and he may have latent TB infection. And in this population, you should treat everyone. So,
right.
But again, I'm not,
Christian, I have a question for you. You are talking about countries with high incidence of TBC, high incidence of multi-drug resistance. What are the suggestions that we can give to these countries to improve adherence?
Drug. Okay, super. You mean adherence to MDR TB treatment?
Yes, and adherence to the medical service also.
Yeah. So I mean, first of all, it's important to again speak about opioid substitution therapy. I think because that's still lacking in many of the countries that have a high incidence of MDR TB. So that's really, really important. And then also, I think that the all-oral regimens that now are coming into more and more, becoming more and more available, DPLM in particular, are very promising because you have a short treatment duration of 6 months, and it's all oral. So in combination with oral substitution therapy and maybe also some social services, this would be the combination. Yeah. Thanks.
Yo, María, te quería hacer una pregunta relativa a... es raro hoy en día que haya Mycobacterium avium en personas con VIH, pero las personas con VIH pueden ser trasplantadas, pueden tener enfermedades autoinmunes o tratamientos inmunosupresores, corticoides de larga duración, etc. ¿Tienes alguna información si en este caso, que me imagino que es poco probable, el comportamiento que tienen las personas con VIH es más parecido a la población general o tienen todavía alguna reminiscencia de su estatus VIH?
Muy buena pregunta. No recuerdo ningún trabajo que valore este escenario específico. ¿Así mejor? Sí. Sin embargo, sí que hay algunos trabajos que han mostrado que los pacientes con VIH pueden hacer una enfermedad pulmonar igual que los pacientes que no son inmunocomprometidos. Es decir, que el escenario probable de un paciente VIH con otra inmunosupresión añadida no suponga un doble riesgo. Es decir, que tenga la inmunosupresión por su trasplante o por su tratamiento inmunosupresor, pero si mantiene un buen control, sobre todo un buen control de carga viral y mantenía unos CD4 adecuados, es posible, hay algún trabajo que muestra que tienen una enfermedad parecida a los inmunocompetentes. Y yo creo que este escenario puede ser interesante porque, de hecho, quizá una de las causas por las que esté aumentando en población general la incidencia de micobacterias no tuberculosas sea el uso de otros inmunosupresores o también quizá los mejores niveles de detección, pero quizá el uso de otros inmunosupresores sea el escenario que tú has comentado.
Muy bien, muchas gracias.
Dos preguntas para María. La primera, a ver, en Latinoamérica es usual que los pacientes se diagnostiquen de forma tardía y la presentación o la sospecha de MAC es alta. ¿Consideraría iniciar un aminoglicósido para disminuir la carga basilar en estos pacientes? Es la primera pregunta. Y la segunda, el 48% demostraba que hacían reconstitución inmunológica. Si se plantea usar una estrategia preventiva con esteroides como se hace en tuberculosis para evitar la reconstitución en MAC.
Perfecto. Bueno, respecto a la primera pregunta, el mejor tratamiento de la micobacteria diseminada es el tratamiento antiretroviral. Entonces, creo que no añadiría un tercer fármaco si logro controlar la carga viral del paciente. Es verdad que en el escenario en el que se dan las dos a la vez puede existir reconstitución inmune, pero el tercer fármaco en el que se discute si añadir o no a la citromicina o a claritromicina y etambutol es la rifabutina antes que el aminoglucósido. Es verdad que esto está discutido porque la rifabutina baja los niveles sobre todo de claritromicina, pero sí que se ha visto que en los pacientes que tienen una carga bacilar alta o más posibilidad de hacer resistencias, el tercer fármaco que primero se recomienda añadir es rifabutina antes que aminoglucósido. Y luego, si se consigue controlar bien la carga viral, es el principal factor para poder controlar la enfermedad. Y la segunda pregunta sobre el síndrome de reconstitución inmune, el manejo es muy parecido al manejo de la tuberculosis. No hay datos sobre el uso preventivo de esteroides, pero sí de usar los esteroides para tratarlos cuando aparece el síndrome.
Tenemos una pregunta del chat.
Y luego hay otra aquí, vayan acercando. ¿Hay otra ahí también? Vale. Sería la tercera.
Para la doctora Velasco, del doctor Turrus, en pacientes VIH negativos, por ejemplo, con pacientes con bronquiectasias y con afectación pulmonar por avium, ¿cuánto tiempo mantenemos el tratamiento? ¿Guiándonos por la mejoría clínica o por la negativación de los cultivos? Porque en algunos de esos pacientes no se consigue negativizarlos.
Bueno, también es una buena pregunta porque quizá antes de preguntarse cuánto tiempo hay que mantenerlo es cuándo hay que iniciarlo, porque está discutido si es necesario tratar estos pacientes o no. Depende de los síntomas, si tienen alguna posibilidad de inmunosupresión y de la afectación que está produciendo la micobacteria. Y de hecho están muy descritas las recurrencias. Entonces, lo clásico es que sean tratamientos prolongados, 9, 12 meses, pero quizá esta duración hay que individualizarla mucho en función de la situación clínica del paciente y de la decisión de tratarlo. Hay muchas series en las que no se pone tratamiento a pacientes y no tienen una peor evolución.
Darío García de Viedma from Gregorio Marañón Hospital in Madrid. My question is for Dr. Kraef. Are you aware of any study indicating some impact on exportation of multi-drug strains into the host countries receiving the Ukrainian migrants? Or because I haven't found it still in the literature, do you think it's too early still to detect this potential exportation and transmission, transboundary transmission?
Thank you for the question. I agree. I don't know any good evidence supporting such transmission. I mean, theoretically, it's a possibility, but I think that it should not be overestimated. I think it is probably not a big risk.
Hi, this is Pere Joan Cardona from Can Ruti. I have also in this 3 questions. One for Christoph, very quick. Have you seen a change in the incidence inside Ukraine due to the movement of people, of patients? Have you seen a change of the pattern in TB patients as well?
Well, I think it's still relatively early, but there is some local data that show that HIV incidence is going up, for example. For TB, I don't know.
And there is another for Dinis. Have you seen in this study, it's not the objective, but have you seen a difference in the incidence of TB, actually, taking into account the preventive therapy?
No, there is no difference in TB cases.
Okay. And another for Maria. And avium is also related with the environment. So when you have... Ay, perdona. Pero que está relacionado con las zonas pantanosas, ¿no? Por eso, bueno, se dice, ¿no? Hay muchos estudios clásicos, ¿no? Que hay esta relación con la población vegetal, con esfagnas, con los deltas, ¿no? Que hay un medio ambiente favorable a inducir a que haya crecimiento de esas micobacterias en el ambiente. No sé si esto, bueno, lo habéis valorado, si hay esta relación la has considerado. No he visto, has hablado del tema de las piscinas indoor, pero no parece que en tu exposición tenga que haber este factor del ambiente, ¿no? Cuando parece que está descrito, ¿no?
Totalmente de acuerdo. Lo que he traído son estudios que han demostrado en cortes o que han llegado a objetivar ese mayor riesgo. Pero es verdad que está muy descrito toda lo que has comentado de circunstancias ambientales, de pues en cañerías, la tierra de las macetas, la tierra para mascotas. O sea que hay muchas revisiones que sugieren que eso tiene un papel, pero no se ha hecho el trabajo de objetivar cuantitativamente cuál es el papel. Entonces, ¿por qué he traído estas 2 cuestiones del pescado y la piscina, que son un poco exóticas? Porque hay un trabajo nórdico que muestra la relación estadísticamente significativa, pero no porque haya otros ambientes que a lo mejor tienen y en nuestro entorno tienen mucho más peso. Es porque estaba estadísticamente demostrado, pero toda la razón.
Nathalie, is there still a role for evidence? Because the EACS guidelines put it in the first place, and maybe do you identify beforehand any instance in which evidence could be the first option?
The guidelines rely on, the methodology of the guidelines is you need to have randomized clinical trials showing the efficacy. So we don't have randomized trials showing that dolutegravir is non-inferior to efavirenz and even less superior. So that's why the guidelines state that efavirenz is the first option. I conducted studies on raltegravir, but I start with efavirenz if I can, because of the once daily dosage. Yeah. And so I know that maybe people won't tolerate it very well, so I know that, okay, as a backup, I will switch to something else. and the duration of treatment will be 6 months. At the end of TB treatment, you can switch, etc. So the safest option remains efavirenz, I think, if we look at the data we have. But I know that's not where we're going. I mean, everybody has thrown efavirenz away, so we have to, you know, the WHO really pushed for dolutegravir for very good reasons, but those reasons are not virological, I mean, with regards with TB. So that's why we really need, once again, the concern is to have resistance to dolutegravir maybe 5-10 years from now. It won't be just now, but it will be maybe 5 or 10 years from now.
Bueno, pues,
no hay preguntas en el chat.
Agradecemos a esta gente, les damos un aplauso.
Un aplauso. Recordad que ahora tenemos un descanso hasta las 11:30, si no recuerdo mal. Importante no dejar ninguna cosa de valor en la sala. Y hablamos de tuberculosis, pero también tenemos una infección muy activa ahora, que es la infección COVID, que si hay personas que se encuentran resfriadas en la sala, al ser un ambiente tan cerrado, agradeceremos que se pongan las mascarillas. Gracias.